I will start from from the previous lectures. Uh, as we said, that electrogram display usually the surface ECG and the intracardiac, the height, right atrium, the catheters and CS and the RV. And depend on location of your catheter, you will gotta get the recording. Now, the displays in the exam, you might get like this, or even like this, or a colored one, different kind of labeling. The HRA might be RA or HRA. His might be H or his 1, 2, 3, 4, 5, 6. CS proximal distal or numbers. RV proximal and distal or RVA. So depend on that, and depend on the catheter's locations. If you get a location like this, for example, a catheter can record anything in its way, from starting from the atrium to the ventricle. And the same catheter, you are gonna get different kind of electrograms from the start till the end. So this one will give you just only atrial electrogram, and this one will give the end of the catheter will give you a recording of the ventricular electrograms. In between, you are going to get whatever structures is passing by, like the His area, which is the proximal and distal and so on. But we have different catheters, so you get different catheters recording different things here. We talked about the AH and HV and how can we get recording, and the intervals we talked about. And we are not talking about rate. We talk about duration between event and event. So the duration between the atrial event to the ventricle or to the His, we just calculated by milliseconds rather than by timing rather than the rate, because we are talking about different activities, atrial, His, and the ventricular. And we talked about the early activation versus late activation, and we get this, for example, the right atrium is activated before the left atrium because this is distal CS recording from the left side of the heart. Okay, and we talked about the infrahisian and the suprahisian blocks, and we given examples of the sinus beat versus PAC. That's coming from different sign than the SA node, because SA node is earlier, and here the right atrial electrogram is later than the other activities. So we know that this is a PAC rather than the sinus rhythm, because the activation is totally different. And we know that the PAC can comes from the right side or left side. For example, this one is not coming from the left side because the 1-2 is later than CS910, which is the proximal one. So proximal is telling us that it is most likely right-sided, and the His was earliest, and we know that this is the area of the activation, the early activation. While this one is showing that the early activation was the distal coronary sinus, and the atrial activity is earlier here rather than the right atrium, while here in the sinus rhythm that we get the activation early in the right side, earlier than the left side. Because if you put a line here, you will find that this one is earlier than this one, starting our 0 point. Now, we talked about the Mowat's type 2 and the HV duration and the effect of that. And the on the opposite side, we talked about the short HV, in which there is a delta wave taking care of the HV interval, and that will give you a short HV, because if we say HV duration or interval, then we are starting from the His activation till the first deflection of the V, when the V and the QRS, not the local electrograms. So that will give us a very short interval. And even sometimes you get HV in minus, in which we say that HV is -5 or -10. and that could explain a activity that transmitted from the atrium to the ventricle through an accessory pathway. So you get the deflection or starting of the PQRS in the service ECG before activation of the HIS area. So these are an example of that, and we talked yesterday, the last time, about the concentric versus eccentric, in which activation. We discussed the activation, the retrograde activation, where they're going backward from the ventricle to the atrium through the AV node or via something else, and that's if it is going to an accessory pathway starting or going from the left side. For example, if we compare this to this, both of them has paced ventricular beats, and this VA, let us say VA conduction, this is going with the concentric activation, in which the conduction backward going from the ventricle to the atrium going to the AV node, and the evidence is that the earlier here is 9-10 rather than 1-2. The duration from here to here is shorter than the duration from here to here. While here the pacing in the ventricle is getting even longer, and there is some kind of decremental conduction through the AV node retrogradely and going early in 9-10 rather than 1-2. If you go to the opposite side, you will see that the pacing of the ventricle getting backward to the atrium starting from 1-2, that tells you that there is an accessory pathway getting the electricity from the down up to the atrium via accessory pathway that's located on the left side, and the evidence that the earliest activation in the atrium is the 1-2. Why I'm stressing on these kind of slides that we did last week, because I received a lot of requests that the second lecture, which was last week, was a little bit more difficult. So I wanted really to put some points that for discussion, and I want to just go back into some of these slides. So antegrade stimulation, the AV decremental properties, AV node ERP, atrial ERP, and sinus node recovery time. So in the EP lab, when we put this catheter, we are going to study some kind of properties of the conduction system of the heart. And this conduction system of the heart, including the normal and the abnormal structures. And one of the things that we are doing, we pace the atrium, and we pace the atrium in different ways. And we will, if we pace the atrium, we are going to check mainly 2 or 3 things. One is the atrial tissue, and to see the effective refractory period of the atrial tissue. Now, if we pace the atrium, means that this impulse should go to the ventricle in different ways. One of them is through the AV node, and if there is an accessory pathway. Now, if we pace the atrium at a certain level, a certain rate, then we are going to stress on the AV node, or if there is an accessory pathway. Now, depend on that, the AV node has something called decremental property, in which that the more stress you are stressing on the AV node, the more rate you are going to pace, the longer duration that's going to take to transmit this activity from the atrium to the ventricle. So you will get what we call it winky back. So you get a PR interval from, for example, from 150 milliseconds to 200 milliseconds to 20 to 40 to 80, then it will block. So that we call it decremental AV conduction, or decremental AV property. And AV node ERP, effective refractory period, in which if you pace the atrium, when you are unable to get into the ventricle through the AV node, then you are reaching your effective refractory period of the AV node. Atrial ERP, which is atrial effective refractory period, where we means that the atrial tissue that cannot be stimulated anymore. Sinus node recovery time is probably not important, but some people who are doing it to assess the sinus node function, in which you pace the sinus node at a certain speed. Then you for 1 minute, for 400 milliseconds or 500 milliseconds, 600 milliseconds, to assess when this SA node is going to recover. And sometimes when you use it for, if we are thinking about sinus node dysfunction. For example, this is an atrial pacing at a certain rate, and we say that if we see S1 means that S1 and S1 in all these paced beats, most likely we are talking about fixed paced intervals. And this is a atrial pacing, and you are pacing in the right atrium, high right atrium, and you are conducting to the ventricle. So you are pacing the atrium, you are capturing the atrium. This is the earliest atrial activity here, then followed by the atrial activity in the CS catheter, then conducted through the Hess to the ventricle. Now the same thing happens here, atrial, Hess, ventricle, atrial, Hess, ventricle. So you are expecting that to increase, the AH interval to increase when you stress on the AV node itself. So the AHV, then AHV. This HV has to prolong if you shorten this, the last beat, what we call it from the S1 to S2. S1, the stimulus 1, which is maybe 8 beats or 1 beat or 2 beats, 10 beats, doesn't matter. But most likely, most of the labs, we put it in 8 beats. Now the 8 beats is S1, we call it. The S2 is the one that we are bringing it earlier than the usual. And for example, if we put this one for example, 600 milliseconds, 600, then this is probably 580, 560, 570, 540, 530, 520, to see the effect on the conduction from the atrium to the ventricles, and to see if there is any abnormal conduction through an accessory pathway, or prolongation of the unusual prolongation of the AV node, or what we call it so-called is the dual AV nodal physiology. So that's very clear. The prolongation of the PR interval and the component of the AH interval. And we talked about this winky back phenomena, which is the normal phenomena for a normal physiology, in which if we increase the pacing in the atrium, or we reach a certain limit that the AV node cannot tolerate the atrial rate, then you will start to get the winky back. The PR interval is prolonging, and some labs are getting the AH interval rather than the AV interval. But let us take this as AH interval. AH is 65, AH interval is 101 milliseconds, AH is 127 milliseconds, then there is a block here. So that's the what we call the winky back phenomena. So you could see that the AH, and A, and there is no V here. Okay, then the A started to have the AH again, the same as the first one. Okay. I don't want to take one by one, because probably because of the time that we are going to spend. But some of these slides probably we need probably to take people to interpret. So here is the we said that the AV conduction, and I think we did explain this last time as well. we talked about the S1. If we say the 500, S1 500, S2 400, S1, S2, means that you are talking about 500 as a drive train, from beat to beat, then you are reducing your the last beat, which is the extra stimulus, simulating a PAC, for example, or a BVC, depend on the area that you are pacing. For example, here we are pacing the atrium, and we are pacing at the rate of 500 milliseconds. Then the extra stimulus is 400 milliseconds. So we expect that the AH is gonna be more than the preceding one. So if we decrease this, the S1 to S2 from 400 to 300 milliseconds, you are going to get even longer PR interval in terms of AH interval. And if you get even more, you may block in your AV node conduction, and there is no H here, means that you have super Hessian block, which is normal physiology. So A, and this is the extra stimulus, and the AV node could not tolerate this short duration between the last atrial stimulus and the next atrial stimulus, which is the extra stimulus. There is no V here. Now the same thing that we are performing in the ventricle. So if you pace in the ventricle, you expect the retrograde conduction in a normal people as well, and probably more than 80% of the times. So this V pacing, then atrial recording, V pacing, then atrial recording, because the conduction will go retrogradely through the AV node or the accessory pathway if there is any, and you will get here. Now, if you decrease the activity, if you decrease the extra stimulus duration from the S1 to S2, you make it shorter, you're going to stress on the AV node in the retrograde way to the degree that you get more VA duration, then it's even getting longer. So the VA, when you shorten this duration, you are going to get this atrial activity even later, till you cannot get retrograde activity because you shortened your VV interval by almost, depend on each patient has different numbers, and then they might not tolerate. We talked about something called latency, because that is very important for us when we evaluate the effective refractory period of a certain chambers, the atrium or ventricle, or the conduction through these kind of structures. So when we, the V1 or S1 is fixed here, then we shorten the S1, S2, shorten. Whenever you shorten that, you are going to stretch on the tissue itself of that structure. We are not examining the effect of this on the conduction beyond that tissue. We are testing the tissue property, or tissue of the ventricle or tissue of the atrium. Here we are pacing in the ventricle. So ventricle is immediately depolarized after the last stimulus. The ventricle is taking a little bit more period, more time to be stimulated, and the more time to be stimulated. So there is a duration between the stimulus and the activity of the chambers that we are stimulating. Then the activity is not recorded here because we reached our refractory period. So this is absolute refractory period, and this is, we call it the functional refractory period, in which that the last functional activity that could be recorded before we could not record anymore after the stimulus. This is an example of the refractory period of a tissue. Here's the V stimulus is the S1, then S2. you could see and appreciate the ventricular activity because of the pacing, then recorded ventricular activity, pacing. There is a recording ventricular activity, and there is what we call it latency between the stimulus and the recorded electrograms, and which is what is not here, because this is the time from here to here is okay for the tissue to recover completely, so it can be excited immediately. But while here, because this activity came very early from the preceding one, then the tissue is not really ready to be excited immediately, and will take time to be excited. So you'll get the ventricle a little bit in a late duration, and we call it latency. Now, when we shorten this a little bit more, you are going to get the stimulus, but you are not going to get the ventricular activity. So there is nothing there. You could not see the ventricular activity, and there is only the stimulus, and we call this a absolute refractory period. Okay. Now, عشان نخليها شوية more active وinteractive عشان ما أصير أنا أتكلم all the time. Who's going to take this one? I know that everybody have seen this one, but let us عشان أتأكد أنكم صاحين. صالح.
Okay, can I take it? Okay, I will take it.
Yes.
This is a surface ECG as depicted in this photo, and there is intra-cardiac tracing from the high right atrium.
Yes.
And then Hess and the RBA. So there is a spike, and the atrial spike, as is showed in the intracardiac tracing, which is basing, as in the surface ECG, and also in the intracardiac tracing as well. This spacing is conducted. This is in the high right atrial. This is A. Then the first A in the Hess, which is I think 3-4, the first one. 3-4. This is
it's the same time.
Actually, it is the same.
The same. First one is the right atrium, then transmitted to the through the Hess.
Hess, and then to the RV. This is the concentric normal activity.
Okay, good.
Normal conduction. Sorry.
Good. Excellent.
The second beat is the same.
Yes.
But there is a extrastimulus.
Yes.
Which is to
at
the atrium, but
S2.
S2, but there is A, but there is no V.
So no V.
There is A. There is no V.
There is A, but there is no V. So this the A is here. It's becoming on the ventricular timing, but it's spacing the atrium. Yeah. And there is no His, no V. Okay. Yeah. So no His. Very important. Very important to mention that there is no His as well. Okay, because you could see the His. Yeah. You could see A, H, V. Here there is A, but there is no His and no V. Okay.
Yeah,
so
no
very,
V.
very important. Yeah. So this is.
You can say this is
normal.
Effective refractory.
Yes, this is normal behavior, and this is AV node ERP. If we know that the preceding one is a little bit longer than the preceding beat, I mean the preceding drivetrain. Yeah, what we usually do we do drivetrain, which is 8 beats, then extra stimulus, and let us say that this is 600, 600, 600. Then this one is
this is 500, for example.
200,
so
280, and
200.
The previous one 290, for example, and was conducting. Then the 280 is the effective refractory period of the AV node, and we call it the effective refractory period of the AV node 280 milliseconds at a drive train of 500 milliseconds. So you have to specify.
500, yes.
Yeah.
Okay. Dr. Naif, there is a question by Dr. Naif.
Yes.
دكتور أحمد السلام عليكم.
عليكم السلام ورحمة الله.
حياك الله الله يعطيك العافية.
أهلا.
Can we call this under sensing? I mean, like, the device did not sense the ventricular beat, and it happened during absolute refractory period.
No. Now, if we say under sensing, أول حاجة طبعا this is we call it programmed stimulation. So this is in the EP lab. So this is not recording from a patient with a pacemaker to start with. And here in the EP lab, usually we pace at a certain parameters that we set ourselves in the EP lab itself from beat to beat. It's a program, we call it programmed stimulation. And this programmed stimulation, sometimes we don't care about the activity of the heart itself, so to be able to study the effective refractory period of a structure. And when we do this, we do it in a programmed way. So we say that we do the drive train with the extra stimulus, and this extra stimulus is detected by 10 milliseconds each time, for example, or 20 milliseconds, depending on the lab. And that's to assess the conductivity of the tissue, of the tissue itself, of the chamber, or the followed tissue, which is the AV node or the accessory pathway. So by all means, we cannot call it under sensing or over sensing, because this is a programmed stimulation simply. We are forcing the heart by pacing to see what is the response. Okay.
Thank you. Allah يعطيك العافية.
أحمد السلام عليكم.
وعليكم السلام ياسر.
For the previous slide, yes. And I think the spike here, if we see the service ECG,
yes,
it is the spike coming in the QRS complex.
صحيح.
At the time of the QRS complex.
صحيح.
So this, what we call this syndrome.
Okay. Now, أول حاجة, this is first of all, this is as we said, this is in the EP lab. So we have the opportunity to see this spike. Where is it exactly in the heart? Is it in the atrium or the ventricle? I know that if we don't have the intracardiac, we will not be able to know exactly this spike. Where is it coming from? Is it from atrial? Or is it ventricular? Is it a CS or whatever? But we have the opportunity to have the intracardiac electrogram to see exactly what we are dealing with. Now, then let us take it one by one. We have this spike, and that was the earliest spike, earliest captured beat was in the atrium, in the right atrium, high right atrium. The second one is the same, captured beat in the high right atrium. Now, with this beat, with this spike, where was the captured? Again, it's the atrial tissue. So all of this are atrial tissue. The atrial contraction has been recorded in the high right atrium first, followed by record in the His area. So we know from this that the paced chamber was the right atrium, not anything else. So this is the good opportunity to have the intracardiac electrograms to tell you exactly which area of the heart you are really pacing. Second thing, that with this pacing, you don't have any change in the ventricular shape. So the shape of the ventricle is continued to be the same, means that you are not pacing in the ventricular chamber. Hope answer the question.
Thank you.
You're welcome. So, AV node ERP, we said earlier that if we assess the antegrade property, we can assess the retrograde property of the AV node. And still, I remember a question from one of our colleagues in the first lecture that we did, that depend on the labs, the CS don't be fooled if you see the orders of the CS. For example, if I show this into our colleagues in the EP lab, in our lab, they will not be familiar with this because this one is the opposite direction orders. For example, the distal, the CS distal, they put it up, and CS proximal, they put it down. Therefore, it get you a little bit more difficult difficult orientation. Therefore, I would urge everybody to look for the labeling in the exam before you start answering, because the labeling will tell you a lot. And here, for example, we are pacing the atrium, pacing the atrium, pacing the atrium, atrium. Sorry, the pacing the V, pacing the V, pacing the V, pacing the V, pacing the V. Then last one, the retrograde conduction is the recorded one. Sorry, the pacing in the atrium. Sorry about that. So pacing the atrium, but the recorded one is the CS ostium before the CS distal. So that makes it a little bit more confusing here. Okay, so there's just, I brought this slide just to show you the difference in the orders that you might face in the exam. So let us take it one by one. So the first stimulus is in the right atrium, and followed by the ventricular activity, atrium V, atrium V, atrium V, atrium without V. So this is our ERP, and I think we have seen this phenomena before a while ago. Now, who wants to take this one? Saleh.
Okay, we'll start from the top of the list. Dr. Abdullah Sharafuddin.
السلام عليكم.
سلامة الله.
يعطيك العافية دكتور أحمد.
سلامة الله، حياك الله.
الله يحييك. دكتور عبد الله شرف الدين from Security Forces Hospital.
أهلا وسهلا.
الله يحييك. We'll start surface ECG and with intra-cardiac tracing.
Good.
And it shows there is atrial stimulus.
Excellent.
And it's go through the H and V.
Excellent.
But it's concentric.
Okay.
This is the first.
الكونسنتريك عادة ناخذها إذا كنا pacing في V rather than the A. يعني if we say that
in retrograde.
retrograde conduction هو اللي نركز على eccentric و concentric.
Okay.
Yeah.
So the pacing right atrium.
Yes.
Then the H.
Yes.
Then the V.
Yes.
And the first one in the his, the V, HV.
Good.
Which that means there is no accessory pathway.
Yeah, the ECG is showing that there is no accessory pathway, and probably the HV, although we don't have the exact measures, but doesn't look that there is a delta wave, and the HV looks like to be normal.
Yes. The second one is pacing the right atrium.
Yes.
Then HV.
Yep.
Then the second is 2, extra pacing, decrease the rate.
Yes.
And there is a right atrium, but there is pacing the right atrium, but there is no ventricle.
No ventricle, and there is no atrium. If you could see that here, there is no atrial tissue because this is a ventricular tissue. This is a ventricular activation. Whatever you see here is a ventricular activity. Although the timing is coming at the time of the ventricular activity, and you could see that if there is any atrial activity, you could see it here. For example, here, if there is activity, you should see the atrial activity. What is this? This one?
This is atrium. Yes.
Atrium in the His area. Okay, or in the His area. Now, where is this coming from? From the paced beat.
Yes.
This is the paced stimulus, and this is the atrial tissue. Now this is a paced beat.
Base what, ventricle or atrium?
This is ventricle. This is from the
ventricle.
So AV, and this based beat from the atrial pacing, the HRA. Okay.
Okay.
Now this HRA pacing is not conducted to the ventricle, and not conducted to the atrium as well. Right? So there is no activity resulted from this based beat in the tissue, in the adjacent tissue. So in this situation, if I ask you, now we have this S1, S2. Now this S2, we shortened the S1, S2 here to assess the activity of the tissue beyond the pacing. Now the tissue beyond the pacing is the atrial tissue or the AV node. And we cannot assess the AV node property here unless we are able to stimulate the atrium. So if I ask you what is the effective refractory period of the atrium, of the AV node, would we be able to know it exactly? The answer is no. Simply because we could not get stimulated the atrium. So if you cannot stimulate the atrium, you cannot assess what is beyond that. Definitely.
So Dr. Ahmed, بس in right ventricle there is the S2, there is a wave in the right ventricle. So this is not phase. This is the normal. So this is the native. This one,
for example, this one related to this one. So it's the same as this one. So the atrium ventricle, and this S2 here. Timing, it doesn't matter whether you put it before the atrium or before the ventricle or after the ventricular activity. But here, because we are putting it very early, to the extent we are getting it before the ventricular activity. Okay, so the next atrial, that tells you, no, we are really too early to be able to stimulate the atrium.
Okay.
Yeah.
Dr. Ahmed, السلام عليكم.
Yes. سلامة الله.
معلش البريفيس سلايد. اقدر اقول من الديوريشن from the stimulus to H.
Yes.
وفروم H V اقدر اقول هنا في first degree of block roughly كده.
اول حاجه هي you cannot. اول حاجه you cannot. لانك هنا ما عندنا اي numbers that we can rely on to start with. Okay. We cannot. لأنه ممكن تكون stretched the paper and the rate is very fast. That's number. Number two, this is based rhythm. Okay, paced atrial. So in the paced atrial, we cannot call this as a first degree AV block because that might be a physiological response to certain numbers. I might induce this in anybody who is normal. Okay, so I think we haven't seen this one. This slide, I think we have stopped last time on this slide. Who wants to take this slide? This is a little bit challenging.
اوكي نشوف الدور على مين. الدكتور عبد الله. طيب عبد الله سوري عبد الله الجامعة.
عبد الله الجامع I think.
أو الجامعة anyone. الله يحييهم الاثنين.
السلام عليكم، يعطيكم العافية.
السلام الله وبركاته. الجمعة ولا الجامع؟
الجامع صح دكتور.
حياك الله. أنا أقرأ بالإنجليزي الجامع مكتوب. أوكي. من
وين؟ مستشفى الخبر الجامعي، مستشفى الملك فهد.
حياكم الله.
الله يحييك. This is intra-cardiac tracing showing service ECG lead 1 AVF V1 and V5 high right atrium his distal and mid and CS distal initially and RV.
Excellent.
So this is initially train basing at 400.
Yes.
One is 1 and then is 2 and 280.
طيب. So S1, S2.
Yeah, exactly.
Yeah. Then pacing where? Pacing in the right atrium.
High right atrium.
Good.
And it's conducting from proximal.
Yes.
To distal. We see it in the CS
CS proximal is the earliest, and the distance.
Yeah, it's conducting to ventricle.
Excellent.
And same for S1.
Excellent.
Then the S2, there is no V. And there is no there is A with no Hess.
Okay, what is this? So
this is Hess.
This is Hess. And if there is a Hess here, and what is this?
This is V.
V. طيب ال V اللي هنا كانت هنا صح ولا لا؟ A V. A V. A V get longer here, much longer. That's number one. And let us say what are the differences between this V and these V's here. The AV is longer than the AV here. That's number one. Number two, if we try to look for the H or Hess, if we say that this is the Hess here, do we see any Hess? Yeah, do we see any Hess here?
Yeah, in previous, yeah, this one there is.
Yeah, and I said that this is A and this is V, and maybe there is H here. Okay, but I cannot be 100% sure. It's the same here in the other one. It's the same here in the third one. But here it looks like the Hess is more clear. But what is more clear than all of this?
Conduction.
Delta wave.
Yes, the service electrogram showing delta wave here, delta wave, but the QRS is getting back to normal. صح? Now let us imagine this. Now if we pace the atrium, and this patient has an accessory pathway. Pacing the atrium, and a patient who has an accessory pathway, you are expected to conduct to the ventricle through AV node or an accessory pathway. Both tissues are going to the ventricle, from the atrium to the ventricle. It's the AV node and the accessory pathway. And those two structures has different effective refractory period. So theoretically speaking, if we change our S1 to S2, reducing the S1 to S2, for example, let us say 400, 400, 400, 400, 280, 400, 260, 400, 250, 400, 240, like this, then we are going to evaluate the effective refractory period of all of these structures, the AV node and the accessory pathway. And sometimes the accessory pathway blocks before the AV node. So in this situation, what happens that the accessory pathway is conducting at 400, 400. So the AV is through the accessory pathway, AV through the accessory pathway, AV through the accessory pathway, then AV through the AV node. So the AV node is definitely longer. AH is longer than what we have it here. That's number one. Number two, the Hess starts to appear because it was hidden by the activity through the accessory pathway here. Is that clear?
Yes, yes.
I don't think so. I don't think so.
Okay. Now let us start from beginning. So we are pacing the atrium, pacing the atrium, pacing the atrium, and pacing the atrium. S1, 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 طبعا preceded by a few beats here before, but let's just say S1, 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 S2. So S2 here, why you are pacing the S2? To see the effect on the pacing on the tissue beyond the atrium. So we are pacing the atrium to assess the conduction property of the AV node and the accessory pathway. So we are going to go down with the S2 from let us say 400, 350, 400, 340, 400, 330, 320, 310, 300, 290, 280. Now, if we decrease the S2, we are going to stress on the structures that go into the ventricle, which is the AV node and the accessory pathway. And if we know that each one has different effective refractory period, and most of the time, not always, then we should be able to block in one and conduct in the other, especially if the effective refractory period of the accessory pathway is longer than the effective period refractory period of the AV node. In a way that the AV node will conduct at a faster rate than the accessory pathway. I'll put it in a different way, that if you put somebody on a treadmill who has an accessory pathway which is weaker than the AV node, you expect his ECG or the delta wave to disappear when his rate gets faster, because the accessory pathway will not be able to tolerate faster rates. This is just a simulation of whatever we are talking about. We are simulating the stress on the accessory pathway by reducing what we call the S1 to S2 gradually, till we stress to the extent that we cannot conduct anymore through an accessory pathway. So the conduction will be recovered through the AV node only. This is not in all situations. Sometimes we got it, sometimes we don't get it, and depend on the conduction. If the AV node is stronger in that patient, we are going to get this, and if the AV node is weaker than the accessory pathway, we will never get it. So we will block in both, in the AV node and accessory pathway. So you will get atrial tissue, but you don't have any ventricular tissue. You don't have even the Hess. Hope it's becoming more clear.
Yeah. Okay, but
Dr. Ahmed?
Yes.
Go ahead.
What is the location of accessory from this cardiac tracing?
This is my
because
question.
I didn't see any initial atria wave.
Okay, first of all, the location of accessory pathway, ideally speaking, should be evaluated by the service ECG before the intracardiac. We should not get into the assessment of the location by the intracardiac before thinking where is it from the service ECG. So my question to you, where is this accessory pathway from the ECG rather than the intracardiac? I know that the ECG has only four channels, the lead 1, AVF, V1, V5, but I believe it's enough to tell us exactly where is it.
Actually, with the negative QRS complex in V1,
V1, yes.
Yeah, that means right from the right atrium.
Let us stop at this. You said negative QRS, and
yeah.
I should say negative delta wave.
Yeah.
Okay, negative delta wave, because sometimes you get a negative delta with no clear negativity of the QRS itself. Okay. So negative delta rather than negative QRS. That's number one. So you are talking about negative delta and V1 makes it likely to be
right accessory.
Right-sided. طيب إذا قلنا right-sided.
Left anterior septal.
Why? لا wait. Left anterior.
Inferior septal.
ها؟
Left inferior septal.
طيب خلينا واحدة بس خلينا ما دام عندنا مع الدكتور. من الدكتور؟
سمير من KFMC.
حياك الله. طيب إذا أخذنا V1 negative, delta wave is negative. طيب where is our next stop?
The inferior lead.
Inferior leads.
Yeah.
Again it's negative.
It's negative, yeah.
So if it's negative, where is this coming from?
From the inferior septal.
Posterior ولا anterior?
Posterior.
Yeah, posterior. So let us say this is right posterior, okay? And most likely, it could be posterior septum. But if you have this, it could be posterior septum, or posterior, or even posterior lateral. In this situation, you might need a 12 lead ECG to compare different KRS. But here, if you see one, which is the lateral one, it's really, if it is really very wide, then you are talking about more lateral position rather than septal position. Okay.
Okay.
The intracardiac will little help you about this. Okay. The coronary sinus ostium, the more proximal ones. So this is this is the more proximal, and this is the distal one. Definitely, the relationship between the A and V for distal coronary sinus, which is reflecting the left side, is long. صح?
Yes.
While this one is a little bit shorter. Those two. So CS4 34 is probably shorter than the others. It could represent an area of the posterior septum, but we should not ignore the width of the KRS. Or, ideally speaking, you should see the whole ECG to assess the width of the KRS itself, if it is not here.
My next question: what's the role of adenosine in activation from the atrial or from the ventricles to look for accessory pathway?
Okay, in the EP lab or outside the EP lab?
EP lab, I mean.
The EP lab. In the EP lab, I believe that the rule of adenosine should not be used unless you are really forced for it, because there we know that there is some kind of adenosine response accessory pathway. Some of the accessory pathway might even respond to adenosine, which is very rare, but you can get it, so you will get more dilemma. So my advice, not to use the adenosine unless there is a real need for it. You have to use a lot of, I know that a lot of people are using it, but I think it's making more confusion rather than diagnosis. And we could see a lot of patients who underwent the adenosine injections during the EP study and tend to have a real accessory pathway after that.
Thank you so much, Dr.
Okay, Dr. Ahmed. So assume we haven't this service ECG.
Yes.
How we can say this is accessory pathway?
The relationship between the atrium and ventricle and the 3-4.
Actually, it is difficult to us from this.
Yes, it's definitely difficult, but you cannot unless you. You mean that you have all the whole electrograms or without this one? If you have this one, this one will give you an answer. This one.
Okay.
This one will give you that.
Yes, because the His, it is.
Yes.
Yeah, that is mean the His is very close to the V.
Yes.
Previously.
Yes. So this one gave you the answer clearly.
Okay. Thank you.
I think we have seen this one before, but let us.
Important for example.
Yeah, like just this is very important for exam. So.
Okay, Doctor.
The answer, but let us say take somebody to explain to us.
Okay. Anyone can comment. Anyone can comment.
Very simple.
Yes, I'll take it.
Yes, sure.
Yeah, take it, please.
Yes. First part of the ECG, we have firstly 4 leads of ECG of lead 1 AVF V1 V6. Then we have his intra-cardiac tracing and RV, but I could not see it.
Good.
From the ECG, we have sinus rhythm, P wave and QRS is visible, and on the his intra-cardiac tracing, we can see the A, then H, V, Then AHV, we have also gradual prolongation of the AH interval until we have A, but there is no H, which indicating that this is suprahistian plaque.
Excellent.
Wenkebach.
Yes. What about the second one?
Yeah. The second one, we have V1, V6 surface ECG with his bundle intracardiac tracing, and this is atrial pacing,
yes.
The high right atrial.
Yes.
I have the pacing spike, then A, H, V, then pacing spike A, H, then there's no V. Again, spike A, H, V, then spike A, H, there is no V. So this is 2-to-1 AV block with the infrahistian block.
Excellent. And you could see that from the first one, that the HV is probably prolonged. I know that there is no numbers here, but looks like longer than the AH. So the HV is longer than the AH, means that we are really talking about probably long baseline HV interval. The second thing that you could notice that there is the QRS duration is widening as well. So wide QRS, while here is narrow QRS. So this is very important question in the exam. And with the exam, they will not give you AHV will give you just only his bundle 1, 2, or whatever without this labeling. Good. Okay. Now this is a simple ventricular pacing. So as we said earlier, that if we pace the atrium, we are going to assess the antegrade conduction through the AV node or accessory pathway. It's the same thing for the ventricular pacing, and we are going to assess the retrograde conduction through an accessory pathway or AV node. And we will try to see if there is any presence of accessory pathway in the right side or the left side. The right side might not be apparent very easily with the V pacing, but the left side will be very easy to recognize. So this V pacing, starting from the right ventricle, and as we said, the S1, S1, S1 means that we are talking about most likely same rate, and we are checking the retrograde conduction through the AV node or an accessory pathway. But here we know that this is AV node because it's early at the probably his area, and 1, 2 is late here. So here you could see that the same thing, the his area is A, and the his area is probably here. Might sometimes doesn't appear very, very clearly, but we could see that there is the retrograde conduction, not eccentric. Okay, it's a concentric going through the AV node back to the atrium and the left atrium and the right atrium in the same time. And you know that you just recognize that the VA interval is exactly the same as not increasing. Unless you decrease the rate, you decrease the cycle length, means that you increase the rate of pacing the ventricle, then you get the retrograde conduction delay, then you might have a block at some stage of the AV node and the retrograde conduction. So it's the same as what we are doing in the atrium, we do in the ventricle, and we get what we call the VA decremental conduction property, is that we are pacing the ventricle here and pacing the ventricle here with VA. So here, VA, VA, and VA. So that's the prolongation of the VA interval, because of we are stressing on the AV node and the retrograde conduction direction. It's exactly the same what we are doing in the atrial pacing, and that sometimes will differentiate between the accessory pathway as well. If there is any AV node and accessory pathway in the same time, the same patient, you could see the conduction through the AV node, then a jump to the conduction through the accessory pathway, or the opposite. Then VAERP, if we say the VAERP, ventricular atrial effective refractory period, means that we are checking the retrograde effective refractory period of the structures that conducting from the ventricle to the atrium, whether the AV node or an accessory pathway. In this situation, you are going to get the V. You are going to get the V as a result of the pacing. You are going to get the V, but there is no A. So you could see the VA, VA, and V without A. So that is the effective refractory period of the conduction from the ventricle to the atrium. This is more or less the same as the previous one, but let us take somebody to take this slide, please.
Okay. Dr.
Somebody who's really expert.
Okay. Dr. Muhammad Al Faqih.
Okay, assalamu alaikum.
Rahmatullahi wa barakatuh.
We have an ECG and intra-cardiac tracing. We have based rhythm, RV based stimulus.
How did you know that this RV pacing?
Because with the spike we have in the RV activities here down.
Excellent. So it was RV apex. The first activation was recorded in the RV apex electrogram.
And yeah, S1,
so we have S1, 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 and S2.
Yes.
So if we have this kind of order, so it's S1, 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 S2 in the ventricle, what are the things that we might are looking for? قبل لا نقرا الالكتروجرامز هذه، قبل لا تلتفت للالكتروجرام، لما تشوف انه والله في pacing بالطريقه هذه في الفنتركل. What I'm checking here?
We are checking the retrograde conduction, the refractory period.
Retrograde conduction. Retrograde conduction might be through
AV node or accessory
pathway. What else that we are checking? The effective refractory period of the ventricle as well.
Yes.
So three effective refractory period of the ventricle or the AV node refractory period, or if there is an accessory pathway refractory period as well. Right. هذه at least يعني to have it in mind before you start interpreting، على أساس أنها تكون بالصورة تساعدك في الانتربريتيشن.
Yes.
Yep.
And then after RV we have an RA, which start initially sinus from.
ما تقولي sinus. Is it sinus?
Sorry, coronary sinus.
Yes.
Started from distal to proximal.
Distal to proximal. Oh, this is very interesting.
Which means that left side يعني accessory.
Okay.
Left side accessory.
طيب معنى هذا انه انت عندك accessory pathway in the left side of the heart.
Yes.
Conducting ventricle to the atrium, and when you pace the ventricle, you conduct back to the atrium through that accessory pathway, and the first activity was recorded in the left side atrium. Left atrium. And how do you convince me about it?
We follow HRA up.
Yes.
And then
so HRA was activated after the LA. So this is LA, left atrium, and this is right atrium. So the left atrium was activated before the right atrium.
Yes.
So this is an accessory pathway conduction.
Yes.
Good.
So the same happened in the 1, 2, 3. Same order. Same order. And then in S2 we have an RV stimulus.
Yes. Stimulus.
Yes.
And captured.
And captured, yes.
Yes. What did you notice with this captured beat?
There is latency.
Latency, excellent. So there is time between the spike till the first activity in that chamber.
Yes.
Good.
And then after there is no conduction to the atrium.
Excellent. So this is all of this is V electrograms, and there is no atrial electrograms.
Yes.
So here, what do we call this? Do we call it accessory pathway effective refractory period or AV node refractory period?
Accessory pathway refractory period.
اوكي او ممكن يكون البيشنت هذا الاي في نود حقته والاكسسوري باثوي حقته both has the same effective refractory period. So to be more accurate, you should say this is a VA effective refractory period. We don't know which one is which. It's through which structure. I know that somebody will say, well, this is through the accessory pathway. طيب ممكن تكون الاي في نود شغاله لا زالت في الوقت هذا.
Yes.
ممكن still, but it's hidden by the activity of the accessory pathway. So therefore, when you block in the retrograde conduction here, in the presence of the accessory pathway conduction, then we don't know which one is really there. يمكن البيشنت ما عنده أصلاً VA conduction, لكن it was hidden by the conduction of the accessory pathway.
Yes.
Good. Any question about this slide? Everybody's happy. Now, this is ventricular effective refractory period. So we are pacing the ventricle at a certain time, S1, S1, then S2. And you remember here, this is this an accessory pathway or not?
We have HIS, we don't have coronary sinus, but the activation is almost proximal first.
Yes, HIS is very early. So HIS is very early, very unlikely إنه يكون عندك accessory pathway here and retrograde conduction. For antegrade, there is no accessory pathway. So retrograde is we are pacing the ventricle, and we are checking the VA conduction. But still, here when we go down in the S2, you are going to miss the conduction through the tissue of the ventricle. So you are not going to even stimulate the tissue of the ventricle. So here we are pacing the ventricle, capturing, pacing the ventricle, capturing, pacing the ventricle, no capture. So no capture عندك two reasons. One of the reasons that you are reaching the effective refractory period, or the output is very low. Okay, but we know that the output is okay, so it's capturing all the time. Why here not? So this is definitely the effective refractory period of the tissue of the ventricle.
معلش يا دكتور ممكن نرجع على السلايد اللي قبلها
هذا.
This.
Yes.
طيب. Pacing in the ventricle in the apex.
Yes.
The first activity noticed in the actually in the proximal HIS.
When the proximal HIS?
Yeah, in HIS proximal.
Wait. Activity of atrial or ventricular?
Yeah, and the after the ventricle, it's activated. Then based and captured.
First of all, this is ventricular or atrial?
Ventricular.
This is V. This is V axial.
ممتاز. وهذه
هذا VA.
This is
VA. Yes.
Which one is the proximal? Which one is the distal?
Which is the proximal? It is proximal distal. CS distal.
This is distal. And this is proximal.
Yeah.
طيب لما تحط خط هنا.
إيه خلاص انتهى.
Got it? عشان كذا أقول كأنها معكوسة ترى. عشان كذا don't default في الإكزام. مع كل لما أحط لك إياها الأوستيال هنا والدستال هنا حتختلف، حتصير بالعكس. You have to be very, very careful in that.
Dr. Sharafuddin عنده question. He has a
Yes.
question.
Dr. Ahmed, can you call this orthodromic AVRT or?
Well, this is during pacing, so you cannot call it. This is during pacing, so we don't know. So
if without pacing can be or just to live as accessory. There is accessory pathology.
لأن أنت ما عندك service ECG during sinus rhythm و during tachycardia. الأورثودروميك والأنتيدروميك هي the conduction of the accessory pathway and the AV node during tachycardia. This is not during tachycardia. يعني إذا قلنا orthodromic والأنتيدروميك هي simply describing الأورثو طبعا through antegrade through the AV node, retrograde through the accessory pathway. العكس antegrade through the accessory pathway, backward through the AV node. Here, I know that you are talking about the backward through the accessory pathway, but this is not during tachycardia. This is during pacing. So we cannot call it orthodromic or antidromic. Yeah.
Okay.
But this is part of the assimilation. Let us say this is a simulation of orthodromic. Okay, but it's not.
Okay.
Yeah. Any other question? طيب. Who wants to take this one?
ممكن دكتور العنزي ولا دكتور عابد إمام؟
Okay, I will take this. Dr. Abid from PhD. So here in this tracing, we will see the surface ECG, and we have the lead 1 AVF, V1, V6, and then the intracardiac tracing, including HRA, his proximal, mid, distal, then coronary sinus 2, 3, 4, and distal.
Yes.
And then RV. And we have drive train RV pacing stimulus in the RV 390, 393, then 380, 380, and 380.
Good.
And here we can see, we'll start from this RV stimulus, and after RV stimulus, then the earliest activation is in the, here we can see the his, RV stimulus in the his, and then we have the A. So A is coronary sinus distal, then we'll see the distal, and then we'll come up to coronary sinus 2, then HRA. So and the first activation is in the coronary sinus 2 and distally towards the left side. I will say the left side.
So this one probably, and I cannot comment about this because usually because they said that 2, 3, 4 distal, which is really very odd for me. But ideally speaking, it could be the proximal distal or distal proximal, regardless. Anyway, regardless, we know that the distal is the latest. Okay, so here distal is latest. So don't worry about it. It means that we are talking about probably right-sided. And the evidence in that the HIS probably is as early as any of the CS things, and the right atrium is after the HIS in the atrial activity. So this is V pacing, checking the ventricular-atrial activities, the retrograde activity. So VA, then?
And then again, stimulus in the ventricle, then we have the same VA.
Yes, then?
And then the stimulus is earlier, at 380.
Yes.
And again, we have VA.
Here. Okay.
The V2A interval is the same.
More or less the same, yes. Yeah.
And then again, the next stimulus, same 380 at 380 millisecond. Here we will see the V, but there is no A.
No A. Good.
Yeah. And we lost the A here. So, and there is the next, when we'll give the next stimulus at the same, here we see V and A.
Yes. So the VA has recovered. So IV node has recovered after this.
Yes.
Okay.
And then, yes. And the next stimulus, we have V, and again we have no A.
No A. So we don't know. Maybe it is a little bit far away, but it's very unlikely because we know that the duration is as short as this one. So if we are going to get the VA, the A should be somewhere here, but there is nothing here. So definitely there is no A here. So here we are reaching the refractory period of the
V to
AV node. Okay.
AV node.
Because we know this, because we know that this is a VA conduction through the AV node. Now, let me ask you a question. Do you think that the VA duration here is the same as the VA duration here?
After the block, it's shorter than
it's shorter. This is shorter than this one. So what does this tells me?
This could be type 1 and Mobitz type 2.
Oh, no, we don't call it Mobitz type 1 or 2 in the retrograde. Decremental conduction. So what does decremental conduction mean? Means that there is no accessory pathway. Very unlikely to have an accessory pathway in this situation. Means that you are conducting backward through the AV node, not an accessory pathway. And the evidence that the conduction goes back to normal or shorter after the recovery. Yes.
Dr. Ahmed, I think there is a clue also. This is AV. If we see the distal and the left atrium and right atrium, yes. I think the A almost the same, or it is coming early in the left side.
The left side, no, distal. distal is latest. The distal is the latest. تقريبا مع هذه معناها انه الكوندكشن probably through the his.
اتكلم عن high right atrium دكتور.
High right atrium عادة during the V pacing and the presence of conduction through the AV node only, usually the high right atrium and the left atrium depicted by the CS distal usually are having the same timing. And usually the curves like this and going early, usually in the His area because the conduction through the His in a normal situation.
Yes.
Okay. Okay. Now I think we have something like this earlier. Can somebody take this one, please?
Yes, I can continue.
Yes, Doctor.
Yes, Fahmi.
Oh,
yes, Doctor.
Fahmi.
Yeah, this
أنا
is.
ما أعطيتك إلا. يلا go ahead.
This is. لأن المشكلة لو بالحروف ما راح أوصل أنا.
Okay.
هنبقى في الA والB طول اليوم.
خلاص next time نبدأ بالعكس.
طيب دكتور, this is ECG and intra-cardiac tracing. I can see in the ECG, or I will go to the intra-cardiac tracing. There is in the high right atrium looks sinus. Then in the His بعدين AHV. Okay. In CS there is conduction from proximal to distal. It's normal conduction. That means RF. Then the conduction to the ventricle. What I can get here, there is in ECG there is delta wave.
طيب.
Yeah. So and there is short. I cannot collect, but I think if we collect the A to the initial V in the ECG will be short also.
طيب خلينا نركز شوي. خلينا نركز واحدة. This is the service ECG. Okay. And you think that there is a delta wave in the ECG?
Yes.
صح؟ طيب.
Yes.
We are not going to discuss the location of the accessory now. although it's so easy to get the accessory pathway location from only those 3 or 4 electrograms.
Yes.
بعدين عندنا الهاي رايت اتريوم، عندنا الهس، عندنا السي اس، وعندنا الار في.
Yes.
طيب now انت you mentioned AHV a while ago. In your description a while ago you said AHV. Do you see really AHV here?
No, I see AV actually.
AV. طيب شوف AV والH is
AV, no clear H.
Yeah. Hidden. The H is hidden. Maybe the H is somewhere here. Maybe, and I cannot say 100%. But what I see that the V is very early and almost fused together. Right. Now let us concentrate on the CS electrograms. So this is the CS ostium, and this is the CS distal, and this is the ventricular activity. This is the atrial activity.
Okay.
Where is the earliest ventricular activity?
The earliest atrial?
Ventricular, earliest ventricular activity.
Ventricular and the ostial, sorry, and the distal.
Distal. So distal CS has the earliest ventricular activity. Right. Now, why do we have this in this patient or in this electrogram? We could see that the ventricular electrograms is bigger than what we have seen a while ago. Let me see if we can get there's one a while ago. I don't know without pacing, and I need to see. Yes, let us see this ventricular electrogram. This is A and V. صح ولا لا?
Yes.
A and V. You see that the V is small. صح ولا لا? Smaller than what we seeing in the A.
Yes.
صح? طيب
Yes.
while this one this one, the ventricular is probably bigger than what we see. This is A and big V. What could be the explanation for that?
Accessory pathway.
No, has nothing to do with that.
So maybe the
site of catheter.
Catheter position. Catheter position will play a major role in the electrograms. Okay. Now, sometimes in the coronary sinus, you cannot go to the main coronary sinus, and some people would push it into a lateral vein. If you put it into a lateral vein, you are going to record more ventricular than the atrial. While if you put it in the main coronary sinus, you are going to record more atrial than the ventricular. Okay, so in this patient, I would say that probably it was done and it was in a position that recording more ventricular than the atrial. Therefore, you get more ventricular electrogram, more size than the size of the atrial electrogram. This sometimes in the EP lab matters a lot. Therefore, you need really to position your catheter in a very good way, and you ensure the good position and good recording. Because that will change your mind regarding the arrhythmias. Now, as you said that this is A and this is V, صح? And we said that which one is the earliest, Fahmi?
The distal.
The distal is earlier than proximal. So what does that mean? This is during sinus rhythm. لاحظ, during sinus rhythm.
Yes.
Where is this accessory pathway? The right-sided.
In distal, that's mean activity in the left more.
Yes, بما أنه activity in the left atrium has been recorded earlier than the left side, means that we are talking about left side accessory pathway. طيب, can we know this from the ECG to start with?
No. And the ECG here, this is going with left bundle branch block.
Okay.
Yeah. And ECG, I will think in the right.
That's so the
right accessory pathway.
ECG looks like انها right accessory pathway. صح؟
Yes. Yes.
وعندك ال AVF is anterior يعني
inferior.
anterior لأنه positive delta and the V1 is negative. So this is very deceiving. So whenever you see an ECG like this, so you are really in dilemma. So you need, in this situation, you need to see V2. V2 might solve the problem in this patient. Okay, but all the time you need to concentrate on the ECG first, then the intra-cardiac.
Okay. Yes. One question.
Ahmed?
Yes, please.
You said there is you should fix the catheter position and
Yes.
CS if the V more than A. What's the if the is not the position the cause? What's the other pathological definition that we have dilemma with it?
No, this is the only explanation. If you put your catheter in a proper way, you don't get this big V.
Okay.
There was another
معلش. You said that the early activation in the distal or proximal.
Yes.
أنا أشوفها كأنه RA.
Yes.
ال early activation.
RA. RA هي sinus rhythm فأنت ما you don't depend on it.
And the pacing طيب.
Yes. Yeah, it's not pacing. هذه just only line.
هذه not pacing. Okay.
Yes. لكن
So
the argument here regarding this, I would say I expected somebody to argue regarding this recording. So the V in the His area. Okay, the V in the His area looks like an early, but in the presence of early activation for left side before the right side, that's one will not be counted here.
Okay. Thank you.
ال HA 0 or negative here, صح؟
HV قصدك.
HV sorry.
Yes. But you don't have a clear HV here.
Because it's not there يعني. عشان كده ممكن تكون negative here.
Yes.
دكتور احمد ال V2 بالنسبه لل V2 لو موجوده بالنسبه للاكسسوري
V2 sometimes will tell you about the ممكن يكون the location of the V1 might not be an accurate location. Will transition between the V1 and V2 is very important in the presence of accessory pathway. So if you get negative V1 and clearly positive or highly positive delta and V2, that's really
left side.
Might push into the left side.
Ahmed?
Yes, please.
Previous slide. I can tell this is lateral accessory pathway from CS catheter AV distal coming early than proximal. I can tell.
It is. That's what we are saying. That because of this is earlier and the distal, it is left-sided accessory pathway. Yeah.
No. I mean AV. The AV from the CS. AV shorter في الديستال shorter في الديستال than the proximal.
Not you need really to the activation pattern rather than the shortness. So suppose that this is longer than this one, but the earliest is this one, then it is left-sided. So the activation rather than the duration between the A and V will be considered.
I applied the concept of AP lab. During AP lab, we are measuring the earliest to our point. So I think this is coming early.
Yes, but we don't consider this. We put a line. We put a line, and our standard is the line rather than the A.
Yes.
Our reference is the line. You just draw a line, and you see which one is the earliest.
Yeah, I saw it just only roughly. Okay.
Roughly might help, but might make you confused a little bit.
Yes.
So let me just give you one slide. I think we don't want really to go deep into the atrial flutter. طيب لو جالك السلايد هذا في الإكزام how do you interpret؟ مين اللي هياخذ هذا؟
Okay.
Yes.
I will try.
Try.
This is just this is the catheter which with a lot of markers. Yani these recordings along the left atrium, والاسمس and the high right atrium.
طيب خليني
Okay.
ارجع two slides before to show you
okay.
catheter. This catheter, this is the LAO view. طيب, for you to understand the concept of this recording, this is the LAO view, and this is the catheter, and that's what's the catheter location in relation to the anatomical structures. So this is the right atrium, this is the left atrium, and this is the coronary sinus. Coronary sinus is here. So we are going from the IVC, from the vertebral cava. We're putting this catheter in the right atrium. This is the lateral wall of the right atrium. And we are going back to the coronary sinus, recording the left atrium as well. So, yalla.
Okay. The surface ECG showed in the lead 1 and the AVF V1. We have these three QRS complexes. In between, there is a lot of atrial activity in between. Let us start from the first QRS complex, which is the first activation is in the 10 in the high right atrium, or the junction of the SPC with the right atrium. Then the 9 lateral wall, and then down to the tricuspid isthmus. Then again back to the one in the left atrium, the last activation in the left atrium. Then again back, the same cycle repeated, and 1, 2, 3, 4, almost 3 cycles. So three atrial activity and 1 QRS complex.
Is it 3 بس؟ وين راحت هذه طيب؟
1 2 4.
4. So
4
this one, 1, 2,
3, 4. So yeah, QRS complex.
1,
and then again
2, 3, 4, 1 QRS.
Yes.
Right.
Yeah.
So we don't have the timing here. Okay. We don't have the timing, but most likely these small calibers is 100.
Yeah.
It's 100. Each one is 100. So if we say that each one is 100, almost this is 200.
200 260,000
معناها الريت كم يصير إذا كان عندكم 200 ملي seconds؟
300.
Yes. 300 is consistent with
the atrial flutter.
Atrial flutter. طيب. Is this atrial flutter can be diagnosed from the surface ECG here?
Actually, can be, but based on the rates. But yeah, I see there is continuous activity in the AVF.
Yes. Yes.
Yeah, there is continuous activity. Can be diagnosed, yes, from this service.
ممتاز. طيب, is this what you call it, typical or atypical flutter? Typical flutter.
Typical. This is typical. Yes, it is started from the lateral down to the isthmus, and and in the looks like reentrant like this. From the lateral wall, started from the through the isthmus, tricuspid.
Would you consider it as counterclock or clockwise?
This is clockwise.
Clockwise?
Yeah, clockwise.
Clockwise.
Counter clock, sorry. Counter clock. So counter, sorry. Counter. Sorry, counter because the first one in do 10.
First one.
And so in the 10 lateral. Yeah, this is the one.
Going this way.
Yes, in the 10, then the lateral wall. Yes, and then down to the.
ليش الcounter? Without knowing this, without seeing the intracardiac, would you be able to say this is counterclock?
Yes,
negative
it is the atrial activity up and then down.
Yes, negative.
From the lateral, yes.
Negative.
You can say that.
Negative. Yeah.
Negative. Sure.
So that goes more with the counterclockwise.
Yeah, counterclock.
Why the counterclockwise gives you negative P waves? Why not positive?
Because the activation started from the up, down.
Up, down. طيب. الclockwise أيضا up, down.
But it is on the other side.
When the other side?
Because it is.
Okay.
Because it's away from the normal direction of flow of the electrical impulse. That's why it's negative.
Yes. I'll tell you just one small piece of information. This has something to do with the breakthrough from the right atrium to the left atrium. If you break through down, you are going to stimulate the left atrium from down. So that will give you the negative P wave. If you get this one clockwise, means that you are going to stimulate the left atrium starting from up, means that you are going to get a positive P wave. So this is the clockwise and the counterclockwise. The breakthrough, if it is up, then this is a clockwise. If it is down, then this is a counterclock. Okay? So both of them should, theoretically speaking, if we are thinking about clockwise going up, down, counter going up, down, both of them should give you negative if we are talking this way. Saleh?
Sure.
Yeah. So this is the electrogram that you are going to see if they are going to give you the atrial flutter and the So it's as easy as this.
طيب دكتور أحمد.
Yes.
How to differentiate the atrial tachycardia and the tracing?
Okay. طبعا I don't have the atrial tachycardia now in my slides, but generally speaking, there are few things to keep in mind. One, always you have to concentrate on the service ECG. Always. Okay. So service ECG is a very important part of your assessment in the EP lab. Don't concentrate on the intracardiac while forgetting the service ECG. The service ECG, first of all, as we said earlier, that the atrial tachycardia will not show continuous activity, will show focal activity. Isoelectric line and P wave, isoelectric line, P wave. While this one is a continuous activity, as mentioned by Saleh a while ago. Second thing is the rate, AA interval. If it is, there is no certain numbers, but the people referring to 250. Anything less than 250 might represent atrial tachycardia. Anything more than 250 might represent atrial flutter. Having said that, in a patient with this very wide, very huge right atrium, for example, might get a slow flutter, we call it. Slow flutter means that because the time for the circuit is going to be longer than the usual, therefore the duration will be less than more than 250 milliseconds or 200 milliseconds. Might be 300 milliseconds or even. So sometimes it's difficult. Then you have to put everything together. the intracardiac as well as the service electrograms in conjunction with the rate of the
what about the pattern VAAV?
VAAV هذه during pacing. If you have atrial tachycardia and if you pace, the VAAV is a differentiation between the atrial tachycardia and other form of narrow complex like the AV-NRT or accessory pathway, not with the flutter. Flutter is always a VAAV. Actually, flutter with VAAAV. Okay.
Okay.
Okay, I think that was the last slide for tonight because I think we have taken more than probably 1 hour and a half, 2 hours almost. Yes.
In this tracing, Dr. Ahmed, all this is atrial activity or atrial flutter activity because QRS, يعني, we can differentiate QRS complex.
What is this?
This one. This one. Yes.
And what is this? So, yes. in a situation like this, follow the service ECG and put a line. Service yes. ECG, put a line. Service ECG, put a line. So you'll find this one is only available whenever you have the QRS, and that's what I mentioned a while ago. If you put your catheter in an atrial position, you are not going to record the ventricular position, ventricular activity. And that's a proof for that. The one that recording the ventricle is only 1, 2, almost 1, 2, شوية with 3. While the others are not recording the ventricular activity. Okay? Because the position of the catheter.
Okay.
Yes, yes.
طيب دكتور أحمد.
Yes.
4:1, sir?
Well, 4:1, yes.
Yeah. Okay. I think we are done, boss. Thank you for what you have
معلش
done
صالح
for us.
في سؤال أخير دكتور أحمد.
سؤال أخير يلا.
Okay.
دكتور أحمد معلش I want to clarify some point. I decide the early activation is different in patient with pacing and non-pacing. I will see the ventricular signal in patients in non-pacing. طيب الباسing نفس الشيء ولا بشوف الاتريال signal for early activation decision?
For the
early activation.
For the atrial flutter يمين ولا؟
لا ما نسأل in general accessory pathway ولا AV-NRT.
You mean the early activation? Early activation is in all situation during pacing without pacing. For example, if I put my catheter during sinus rhythm and somebody who has a lateral accessory pathway, definitely I'm going to get the activation of the left atrium earlier than the left ventricle earlier than the right ventricle, for example.
So the ventricle, not atrial.
Yes, no, both, all of them. If I put my catheter and the patient went into tachycardia, for example, spontaneously, and I will record the activity. I will see which area is activated before. So if he developed orthodromic tachycardia, then definitely he will have the early activation on the left side of the accessory pathway on the left side, without pacing. Okay. So with spontaneous tachycardia, I'm going to assist the activation.
Okay, تمام. يعني I mean I will see the ventricle or the atrial. The one is earlier.
All of them. Oh yes, all of them applicable during pacing, without pacing, atrium or ventricle.
Okay. Okay. Thank you. شكرا دكتور. شكرا.